Morning, everyone.
Good morning.
Thanks for saying that, Brandon. No one else wants to say anything to me.
I think they're all embarrassed to have other people hear them.
Okay.
Hey.
So, good morning. So, looks like it's 9 o'clock now, so I guess we can go ahead and get started. So, I had a question in my email from one of you guys about like what the schedule is for the rest of our tests. So, let's talk about that right off the bat. So, it sounds like they are giving us an extra week of the term. So the 30th is supposed to be when the term is done. So my plan was to do test 1 this Thursday. And then I think there's a couple of people who have to take the dosage calculation 2. So they're also going to do that on Thursday. And then for test 2, I don't know if you guys have a calendar in front of you that you can look at, but so we have so many things to get done. We kind of have to do a test a week, basically. So test 2, I would probably do on the 9th, April 9th. I was thinking test 3 would be the 16th. The ATI funds proctored will probably be on the 23rd. And then I would probably just do the final exam. I would treat it just like we normally would with a Monday and Tuesday. So I'd probably do that on the 27th. Do you guys know when your other exams are going to be for your other
No.
So if someone
Tibbs is trying to have them on Fridays.
Okay, so I shouldn't interfere with anything he's doing then. Is that right?
Right.
Okay. All right, so are you guys okay with what I just said? I just kept them on Thursdays because that's how we originally had it planned anyway. And then I'm trying to space it out so at least we have a little bit of time to talk about things in between.
Yeah, that's good.
Okay. So that's the tentative plan here. I will like type something up and stick it up on Canvas officially so you guys have it written somewhere. Now, as far as rest of things that you would have due for the class, those are still the same. I'm not changing dates on any of that. There's no sense in doing that. So all of your due dates will be the same for your other assignments.
Okay.
So I still am getting a couple of emails from people about vSim and DocuCare. I have given you everything I know about it. So if you're still having issues, you need to contact the IT support people. So when I sent you guys your access codes for vSim individually, you have the IT support number right in there on that paper. And I can repost it on Canvas too if you need me to. But I don't know what else to tell you about what to do with that. So they have to be the ones that do something with you for that. Are there still a lot of you having issues or just a few?
No, it's good.
Okay. All right, and then one other thing I wanted to say before we get into our review stuff. I keep getting a couple of people emailing me about the case studies. So I know some of you are saying you're having a hard time with the websites that they're telling you to go to. I don't think you're giving it enough time to look at it. So when I go to look at it, I can find where I need to go. It may take me a few minutes, but I can find it. So there's nothing that you have to sign up for or register for on these websites. I know it kind of looks like that sometimes, but if you look at it again, there are places that you can go to find this information without you having to do any of that. So if you are still having a hard time with that, please give me a call. I know there's probably like 3 of you who were having an issue. So if you can give me a phone call after we're done after this, and here's my number, 330-256-4043. I can talk to you after I'm done doing all of this, and then hopefully we can get some stuff straightened out with that. Okay. So I just wanted to spend this time this morning doing some reviews so that you feel ready for your test. So that first test should not be that bad for you. So remember, we're going to have the pre-op, intra-op, post-op on it. We're going to have a little bit of stuff about pain. And then the rest of it is going to be about all the orthopedic stuff. So like your stuff about fractures and osteoporosis and rheumatoid and osteoarthritis, all of that kind of stuff. And then there'll be 2 math on it at the end. Your 2 math are going to be 1 milliliters per hour question and 1 drops per minute question. So nice and easy. So that shouldn't be an issue. So let's kind of go back through some of the stuff that we talked about a little bit, just to make sure you guys are remembering important things. Okay, so remember back when we talked about the pre-op stuff, we said that there was different phases to surgery. So you need to know the difference between the different phases. So what did we say pre-op was?
Pre-op starts from the decision to do surgery, and it ends, I think, when you get into the surgery room.
Yeah, you're correct.
Okay.
What about intra-op?
That's from the
Sir-
time when you get taken into surgery until you go to the PACU.
Correct. And then so post-op would be what?
I think post-op is from after surgery to, I think, your first doctor's appointment.
Yeah, and usually that's maybe about 2 weeks afterwards, something like that. So the other big thing that you definitely need to know is when we talked about those different surgical classifications, there is a specific test question about that. So you need to be able to tell the difference between those. So you remember when we talked about diagnostic surgeries? Someone tell me what a diagnostic surgery is. Just give me an example of one.
A biopsy.
Sure. Yeah, a biopsy definitely would be a diagnostic type of a procedure because you're trying to figure out what's wrong with this person. So if you take a biopsy of something, then you can tell, maybe they have cancer or something, and you can tell from that. What is a curative surgery?
A surgery that cures the problem.
Okay, so give me an example of a curative surgery.
Removing a tumor.
Okay. And maybe even like an appendix, getting your appendix out, because hey, if your appendix is inflamed or it ruptures or something, you have to take it out, and then that fixes the problem. You don't have that issue anymore. What about a reconstructive surgery?
That could be like after you have a mastectomy and
Okay,
then go in.
sure. So yeah, if you say you have a mastectomy because you had breast cancer, and then you go back at a later date and you get reconstructive surgery to get another breast put on. So that's definitely reconstructive. What's cosmetic?
Surgery that you really don't need, but it's fixing like a physical problem, but it's not necessary.
Yeah, it's probably something like maybe I get my nose fixed, like a rhinoplasty. Maybe I just don't like how my nose looks, so they mess with my nose. Or if they do any of those like plastic surgery type stuff, like tummy tucks and all of those types of things, that's all cosmetic. And then what would be a palliative surgery be?
That's comfort care. So that could be like debulking a tumor that they can't excise completely.
Okay. So palliative means that whatever, so something's causing you either pain or shortness of breath or some type of discomfort. And by them doing surgery, it's not fixing the problem, but by them doing the surgery, it's helping with your symptoms. So like you said about the debulking of the tumor, maybe the tumor is getting so big that it's pushing on something and it's causing me pain. So if they take part of that out, then I'm not having that pain anymore, so I feel better. What's a rehabilitative surgery?
Something like rehab, so like maybe like a knee surgery or something like that, maybe.
Yeah, so the actual definition of it is restoring something to its original state. So like any of the hip replacements or knee replacements that people get done, so they totally take that joint out and put a brand new one in. So it's restoring something to its original state. Okay, and then at the bottom of this was talking about like emergent, urgent, required, elective, and optional type surgeries. So if you ever have an emergent surgery, this is something that you have to do right now or this person might die. So typically it's something that's going to be pretty extreme, like maybe they have a bunch of bleeding going on or they have a fractured skull or something along those lines. Everything else would be, not as bad. So urgent, this is something that you definitely need to get taken care of soon, but it doesn't necessarily need done right this second. So that would be something like, maybe I have kidney stones. You don't really think of kidney stones being that urgent, but they kind of are. If a kidney stone gets lodged somewhere and you can't have urine flow because of that, that's going to cause bigger problems. Like maybe your bladder could burst or something because you can't get urine flow. Other things, like required, this would be something that you could plan within a few weeks or months. So like maybe I need cataract surgery or something. And so I plan it for, next month or something. So that's not something I need to get done urgently or emergently, but I need to get it done eventually so, I can plan for it. Elective would be something that is kind of up to you to get done or not. So like maybe I have a hernia that really isn't that bad. It's kind of a small one and it's not really causing me a bunch of problems, but I just want to get it done because I don't like how it looks, so I go for that surgery, they fix it. And then optional would be all of your cosmetic type surgeries, so hey, I get my nose done or I get, a facelift or something like that. Okay, so the other big things in the pre-op stuff that I would want you to know about would be some of the things we would be teaching people. So all of this stuff about, hey, this is what you can expect after surgery. These are some of the things I want you to do to prevent complications. And then the other stuff would be like, what kinds of things put people more at risk for complications of surgery. So how we talked about if you're a smoker or if you drink alcohol, that type of stuff. And then, know about informed consent because we talked about that in pre-op stuff. I'm just flipping through here real quick to see what else. Yeah, and then maybe just like, be familiar with some of the medications that you might have to hold before surgery, that type of thing. So let me see here. Okay, can you guys see this?
Yes.
Okay.
Yep, I can see it.
Yes.
Oh, no, I can't see anything. What's going on? Oh, it logged me out. That's why. Okay, so I was just going to do a couple of practice questions with you guys. This is off of the point. So let me see if I can get this to work now. All right, can you guys see that?
Yeah, I can see it.
Okay.
Yes.
Okay, so just, call out if you know what the correct answer is and we'll click it and we'll see if we're right. So regarding the surgical client, which phase refers to the period of time that spans the entire surgical experience?
Perioperative.
There you go. Here we go. Okay. All right. When the indication for surgery is without delay, the nurse recognizes that the surgery will be classified as?
Emergent.
Emergent. There you go. There we go. Okay, when a client with a history of chronic alcoholism is admitted to the hospital for surgery, the nurse anticipates that the client may show signs of alcohol withdrawal delirium during which time period?
I want to say A, right? I hope.
Well,
Maybe.
Let's see if you're right.
Okay.
Yep. When a client is encouraged to concentrate on a pleasant experience or restful scene, the client is using the cognitive coping strategy called?
Imagery.
Yeah, I think so. Yep. Okay, a fractured skull would be classified under which category for surgery?
Emergent.
There you go. In which instance may a surgeon operate without informed consent?
I would say emergency as well, right?
Yeah. There you go. Okay, which nutrient plays an important role in normal blood clotting?
Vitamin K?
Is that what you want me to put?
Yeah.
I can get this stuff. There we go. Okay, clients who have received corticosteroids preoperatively are at risk for what type of insufficiency?
Adrenal?
It's adrenal, definitely. Okay, for
So, oh, sorry. So corticosteroids cause adrenal issues?
yes.
Oh, okay.
For the client who's taking aspirin, it's important to stop taking the medication at least how many days before surgery?
7?
Okay, and this is the last pre-op question. Which domain of perioperative nursing practice focuses on clinical processes and outcomes?
Safety? Maybe?
Let's see.
If it's wrong, I'm sorry.
You're all right. Healthcare systems. That's kind of a dumb question. Okay, so that's that one. Let's see if we can go do another one. I don't know if it'll let me go there. There we go. Let's see if we can do some intra-op ones. Okay, before we start into this, for intra-op, some of the things that you should be thinking about for intra-op. Definitely the difference between the different people in the OR. So, hey, what does the circulatory nurse do? What does the scrub nurse do? You know, all of those types of differences there. Other things that you should focus on in here would be, you know, what is sterile technique? Because in surgery, they have to, you know, be sterile. So there could be a couple of questions on that. And then remember in the intra-op stuff, we talked about the different types of surgery, like the different types of anesthesia. So general, regional, local, conscious sedation, that type of stuff. So what do you remember about general surgery?
Is that the one where they knock you out?
Yes. So you would get put out by either like inhalation mask, you know, like gas that they give you, or they would also maybe give you something in the IV to get you to go out. Now, when you're under in general, you are intubated, correct?
I would say so, yeah.
Yes. So you cannot protect your airway whatsoever during this because you're so relaxed, you don't know what's going on, right? So you are not aware of what's going on around you. You know, as far as pain goes, you wouldn't be able to tell if you were, you know, having pain in a certain area or whatever because you've been laying in a certain position for so long. You know, so there's different things like that to think about with general. So remember, we talked about all those different crazy complications that you could have with general surgery as well. So like we briefly mentioned when people have anesthesia awareness. So that means that they get put under with anesthesia, but they somehow still are moving and they're aware of what's going on, which is a really scary thing. Other things that we talked about that would be complications would be things like hypothermia, anaphylaxis, hypoxia, nausea, vomiting. And then the big one that we really spent a little bit of time on was that malignant hyperthermia, right? What do you guys remember about that?
Those who are like muscular are more prone to get it, and it's like hereditary Um, I forget how it starts though. Doesn't it start with like bradycardia? Maybe?
Tachycardia.
Tachycardia.
Oh, okay. I knew it was something like.
Anyone else have a thought there?
It's when there's too much anesthesia.
Well, it's not necessarily too much anesthesia. It's a certain type of anesthesia that they get that they're allergic to, that they don't realize until they get it, you know?
It's hereditary.
It is hereditary, yes.
And it happens during like stage 4. It can happen.
Well, remember stage 4 of surgery, we don't want to ever happen. So that wouldn't be when it happens. It would happen during stage 3. So let's go back to those stages for a second. So with stage 1 of general anesthesia, that's when they begin your anesthesia. And so when you start getting that infused, you have like, you feel like maybe you can't move all your extremities really well and noises are really exaggerated, that type of stuff. And then stage 2 is that excitement phase. So this is when you might start doing some weird things that are off the wall, like maybe you'll start singing or laughing or crying or weird stuff like that. You could have uncontrolled movements and you need to be restrained in that stage. Stage 3 is where we want people to get to when we do general anesthesia. So during that stage, that's when we can do our surgery and they're not going to realize what's happening. So we want to get to that stage. Stage 4 is the one that we do not want to get to. So this is where you have medullary depression. So this is when you do have too much anesthesia and it can cause big problems. So like you start to get discoloring, you know, like cyanosis. Your pupils get really wide and they don't constrict. You know, it's just a big complication of surgery. Your breathing starts to get really shallow. Your pulse is weak and thready, all of that kind of stuff. So they would have to like do some type of narcotic antagonist or something to like reverse some of your anesthesia to get you out of that, or you could die. So, but what I really want you to know though with general is that you're at risk for a lot of things when you're under because you don't have the ability to speak for yourself, you know. So the nurse then in the surgery is responsible for you. They're your advocate. So you have to think about that. You know, if you work in surgery, you have to be the advocate for that patient then, since they can't say what could be going wrong. All right, what do you remember about regional anesthesia?
Isn't that like an epidural or a spinal?
Yes. So what are they essentially doing by giving you that?
Like numbing. Be like numbing the. So if you get a spinal or epidural, it would numb you from the waist down.
Yeah, exactly. So if you get a regional anesthesia for other things, like maybe they decide to give you regional in your arm because they're going to do some type of arm surgery to you. So they inject you in a certain place in your arm so your whole arm is numb. So with this, you have to be aware of when this wears off because you want to make sure that they get their feeling back, right? So that would be one of your biggest concerns. And then just to realize that because they don't have feeling down there, you know, they could be at risk for other things like skin integrity issues and stuff like that. What can you have happen to you if you get spinal anesthesia as a bad thing that might happen?
Really bad migraines.
Yes, so you could get that spinal headache. So what are we supposed to do to help prevent that?
Hydration?
Hydration does help. What position do we want them in?
Lay them flat.
Yes, lay them supine. And then if some of those simple things don't fix it, then eventually they would take them back to surgery to do what they call a blood patch, and then that would help fix the issue. So what's happening with that is you have spinal fluid that's leaking out that's causing you to have this headache. And so they need to fix the leak, basically. So if they don't fix that leak, like if it doesn't fix itself by doing those simple things, then you have to go in and actually physically fix it. Okay, and then the other two things that we mentioned were moderate sedation and then also local anesthesia. So tell me about moderate sedation. What do you know about that?
You're kind of awake, but you're not.
Okay. So what kinds of things would we give moderate sedation for?
A chest tube
A chest tube,
or colonoscopy.
colonoscopy. There's quite a few things if you really sit there and think about it. But yeah, so for this, it's almost like, you know how everyone always talks about twilight? That's kind of what this is. So basically you give them medicine, it'll put them out, but they're not out completely like they would be for general. They can still, you know, protect their own airway. They can still breathe okay. But you can like arouse them a little bit easier. So like if you really shook them, they would wake up. So with moderate anesthesia, you need to, as the nurse, you need to be monitoring their vitals every couple minutes during the procedure. You need to make sure they have oxygen on, even if they don't normally wear oxygen. And then you need to make sure you have suctioning equipment available just in case their, you know, airway starts to get compromised. So that would be some of the things you would need to know about that. And then with local, this would be like, hey, I have to get, you know, stitches or something like that. They would, you know, inject a local anesthetic into the area to numb it. The nice things about local is that it's fairly cheap and it'll wear off after a little bit. It's not going to be something that they, you know, have numb all day. So those are some of the positives about that. All right, let's look at this real quick. Okay, which stage of anesthesia is referred to as surgical anesthesia?
3. So I guess B maybe.
That's what I'm thinking. Okay. Fentanyl is categorized as which type of intravenous anesthetic agent? Even if you don't know, that's okay. Just give a guess.
Okay.
So it's an opioid. Fentanyl's an opioid. Okay, whoops, skipped over one. Okay, which clinical manifestation is often the earliest sign of malignant hyperthermia?
Well, we talked about it, so tachycardia.
Yeah, there you go. Which would be included as a responsibility of the scrub nurse?
The scrub nurse is about sterility, so I'm thinking B maybe. Probably not.
Thought it was D.
Let's try
Never
that.
mind.
That's okay, you're fine. A nurse who works in the operating room is required to assess the client continuously and protect the client from potential complications. What symptom would the nurse watch for as indicative of malignant hyperthermia? Select all that apply.
A.
B.
Oh, maybe I have to hold this down. Hold on. Trying to get both of them to. Oh, it won't even let me select more than one. So which one do you think the most?
B. or A. Mm, B.
Okay, let's see what that says. Yes.
Hey, good job.
All right. A registered nurse who is responsible for coordinating and documenting client care in the operating room is?
A.
Yeah.
Yeah, I'm thinking A also.
Okay. Which zone of the surgical area only requires attire in the form of scrub clothes and caps? This is another thing that we kind of talked about, but
The
B.
semi-restricted.
Oh,
yeah, so look down here at the bottom. So semi-restricted is where you have scrub clothes and caps. Unrestricted, you can have street clothes, and then restricted, you have the full everything on. Okay, which stage of surgical anesthesia is also known as excitement?
Stage 2, I think.
Yeah. Okay, in which position would a client undergo a lumbar puncture be placed? So if you were getting a lumbar puncture, what's that mean? Lumbar.
slide
What's
your
lumbar?
spine.
Okay. And so knowing that, just knowing what lumbar means, what position do you think this person would need to be in?
Um,
The sideline.
Right.
I
yeah,
would,
C.
I would think so, right? And then which conduction block anesthetizes the nerves supplying the chest, abdominal wall, and extremities? This is kind of hard, so it's fine. You just pick something.
D.
Yeah, I don't, this is kind of oh, look at you. You got it right anyway.
A.
All right, so these are just, practice questions from your book. So obviously, you're not going to have some of these questions, but, I thought maybe this might be a nice way to do a little bit of a review. All right, so then we need to talk about post-op. So what are some things you think were important in the post-op stuff that you should know? What do you guys think?
Early ambulation.
Okay.
Monitoring the vitals and temperature.
Okay. What else? So if you looked through the PowerPoint again, just a second, some of the things that we talked about were the different phases of post-op care. So that would be one. And then, we talked about when someone is in recovery room, they have to meet certain criteria to be able to go to a regular floor, right? And what are some of those criteria? Do you guys remember?
They have to be able to swallow, right?
Okay.
Or something like that, maybe.
What else?
Does that include the scale, or is that just for discharge, the Aldrete scale?
Yeah, they'd be discharged from the recovery room. So yeah, it doesn't necessarily mean that they're going to be discharged home, but if they can, go from there, they need to meet that scale, that Aldrete scale. So remember the Aldrete scale, it has stuff like, let's see if I can see it on here. It has stuff about your vital signs, if you can, activity, like what you can do. God, this is so tiny, I can't see it. But basically their number needs to be between a 7 and a 10 to be able to be discharged from the recovery room. So they need to have stable vital signs, adequate respiratory function, their oxygen sat needs to be fine, those types of things. And then we also talked about like when we get a patient from recovery to the floor and some of the things that we would be assessing right off the bat. What would be the first thing we'd be worried about?
The
Airway.
site.
Airway, airway. So anytime you think of your ABCs, basically, airway is always number one priority with everyone, especially if you're getting someone from surgery, because you want to make sure that they can maintain that airway, that they're not going to be compromised. So what's your B? Breathing, right?
Breathing.
So breathing would be the next thing we'd be worried about. So we want to make sure that they're breathing okay. And then what's our C?
Circulation.
Circulation. So then we'd be worried about their heart a little bit. So that would be things like their blood pressure, what their heart's doing on the heart monitor, that type of stuff. So some of the things that we mentioned, you know, that were possible things that could happen that you would hope wouldn't happen would be shock. So remember we said hypovolemic shock was like one of the biggest things that you might see. And all this means is that you don't have a whole lot of fluid on board after the surgery. So you know how normally we have fluid surrounding our cells, you know, in our circulation, but you know, after surgery, sometimes you lose a lot of blood and you just don't have all of that fluid there. So some of the things that you would see when someone's in shock, they would have a low blood pressure. They may have, like they may look really pale. What are some of the other things you think you would see? Probably a fast pulse. So their heart rate would be going kind of fast. Concentrated urine, you know, those types of things. So what do we do for this? We give them fluids and we may even be giving them units of blood. It just depends on the situation. So typically fluids, like giving them the fluids, that usually will help. But if it doesn't for some reason, then you would have to move on to, you know, more serious drugs that would help keep their blood pressure and everything up, right? Let's see, what else? Okay, so some of the other stuff we talked about would be post-op nursing interventions. So things that are important to do after surgery to help prevent complications. So name some of those. You guys still with me?
Clotting.
I just heard clotting. What did you say?
Like venous, oh gosh, VTE.
Okay, so we'd be worried about VTE. So what would we do to prevent that from happening?
Anti-embolic stockings or ambulation.
Okay, so
Get
early
them up and moving.
ambulation, get them up and moving quick, have the SCD pumps on their legs, maybe do, you know, sub-Q heparin, something like that.
Breathing.
You do the breathing, the incentive spirometer, stuff like that.
Okay, definitely. So coughing and deep breathing, incentive spirometer.
Monitoring vitals and like skin warmth and moisture.
Okay. Anything else we're worried about as a possible complication that we could do something about? Do you guys remember delirium? So delirium's a really big complication after surgery, especially with older adults. So remember that there's a ton of different things that can cause delirium. And delirium is something that is going to happen kind of quickly, after the surgery, but it's not something that will last if you fix the actual underlying problem. So typically people who are more at risk for this would be people who are older, people who have a history of alcohol abuse, people who have messed up electrolytes in labs, and also people who maybe just have a decreased cognitive function baseline. So some of the things that can cause it, would be infection, hypoxia, dehydration, medications, urinary retention. There's a ton of things that can cause it. So you have to kind of figure out what it is. And then once you fix that, then they get back to normal. What's something that we would be worried about with their wound?
That it stays not infected. Like you would watch for like drainage and pus and things like that.
Okay. So when we're looking at someone's wound, we want to see that it's well approximated, that it's, the edges are closed up, that we don't see increased redness around there. You generally will see a little bit of redness right after surgery, but we don't want it to look like angry red, right? Then with drainage, we want to see that decrease over time. We don't want to see it increase, right? And then we don't want it to be that purulent looking drainage that has a smell to it, that looks funny and has a weird color. We want it to be more like serious looking. What about wound dehiscence and evisceration? What do you remember about that?
You should splint, like, if you have abdominal wounds, so it won't dehiscence or eviscerate.
Okay.
Yeah, and
Sometimes it'll happen regardless if you do that or not, but
Okay.
So if I remember, dehissing is where like it opens up, but eviscerating is like all the insides come out through the wound, which is gross as heck.
yeah. So you would never want to push that back in, right? So
you kind of hold it with saline or something like
Yeah.
that.
So we do a saline soaked dressing over top of that. And it needs to be like a sterile type of a dressing. And then you would stay with the patient, because when this happens, typically they'll call out to you and they'll be like, oh, I just coughed and I felt something give way. Can you take a look at my wound? And then you'll look and you'll see that it's happening. Once the patient realizes what's happening, they may start to go into shock. So you would want to stay with them at the bedside and take care of the dressing, and then call out to someone in the hallway to call the physician. So the physician would have to come, and generally they would have to take them, to fix that back to surgery. Okay, some other things I just want you to remember. Towards the end, when we talked about all this stuff, we mentioned stuff about altered bowel function. What could be some things that we could do to help with that? So constipation is always an issue after surgery. So what can we do for that?
Ambulation.
Okay. What else?
Stool softener.
Stool softeners, I heard someone say. Yes, we could do that.
If they are able to give fluids,
Okay.
maybe.
Yeah. So those would be the basic things we would do. And you always want to do that 3-day rule. And so if someone hasn't gone after 3 days, you need to be giving them something to help them go. So this can turn into bigger problems if you don't treat their constipation. They can end up having a bowel blockage and end up having to have surgery for that. So huge deal. Then with pneumonia and atelectasis, what's the difference between the two?
Pneumonia is it's like an infection in your respiratory system. Atelectasis is your lungs are, what is it? like your lung, ugh, it
Isn't that when your lung collapse?
yeah, lung collapse.
Okay, so your lung doesn't collapse with it, but you're kind of right. It's the air sacs in your lung. Okay, so with atelectasis, the air sacs in your lung collapse. So it doesn't make your lung collapse, it's just the air sacs. So they don't expand properly, so you can't have good gas exchange. So atelectasis would be like a precursor to pneumonia. So when you start getting that, you don't generally have a whole lot of symptoms, but sometimes you'll have like decreased breath sounds there. You may have a little bit of an increase in temperature, you know, maybe like 99 point whatever. So you need to get someone to start doing their incentive spirometer at that point so they can like pop open these air sacs and so it doesn't turn into pneumonia. So pneumonia would be an actual infection that inflames the air sacs. So the air sacs can fill with fluid or pus and it causes them to cough and have lots of phlegm. So again, they would have a problem with gas exchange and they tend to desat and need oxygen and all kinds of stuff. So what can we do to help with atelectasis and pneumonia?
The incentive spirometer.
Yeah, that's the big thing. What else?
Antibiotics.
Antibiotics, okay. Usually you're only going to do that if they have pneumonia. What else?
Like the chest physiotherapy.
There you go. That's what I was waiting for someone to say. Okay, so remember, chest physiotherapy is a great intervention that you can do for these people. So remember, it involves three things. So they have that one thing where you can position them in different positions every 15 minutes to like get those secretions to move in a certain place so that they'll be easier to cough up or suction out. Then there is the cupping that they do where you like, not really slap them, but kind of slap them on the back to get some of that loose. So again, they can either cough it out or you can suction it out. And then they also have the vibration, which is like it's a vest that they would put on them that shakes them. And it helps get some of those secretions loose so they can get it out a little easier. So yeah, those would be things you would want to be concerned about with this. All right, so let's look at this quiz real quick. See if we can answer some of these. Which term refers to the protrusion of abdominal organs through the surgical incision?
A.
There you go. Which method of wound healing is one in which wound edges are not surgically approximated and integumentary continuity is restored by granulation? Do you guys remember this? Because I didn't talk about it.
A, second intention healing.
Third, I think.
So it's probably going to be this one. So this is the thing. Remember with third, you're going to have like a really deep wound, and it's usually going to be someone who's already infected that when they do the surgery, they're going to keep it open for a couple of days to let that infection seep out, and then they'll take them back in a few days to close it up. So they'll actually reclose it. With second intention, they never close the wound. It has to heal by granulation tissue forming in there. So think of like a pressure ulcer of some sort that's kind of deep. You know, as that heals, you don't like suture it together to get it to be closed. You let that heal in on its own. You guys understand what I'm saying?
Yes.
Okay. All right, the nurse recognizes which symptom as a clinical manifestation of shock?
C.
Yeah, I'm thinking C also.
Okay, when the nurse observes that a post-op client demonstrates a constant low level of oxygen saturation, although the patient's breathing appears normal, the nurse identifies that the patient may be suffering from which type of hypoxemia? It's just make a guess. It's okay if you don't know.
D. I don't know.
Subacute. That's fine. You don't need to know that. Okay, when the surgeon performs an appendectomy, the nurse recognizes that the surgical category will be identified as what?
That's kind of a weird question.
It is weird. Just give me an answer. It's okay.
B,
It's
why
not-
not?
It's not something that you would have on your test anyway. Gee whiz. My computer is not wanting to let me click on this. There we go. Clean contaminated.
Whatever that is.
So they're saying clean contaminated cases are those with a potential limited source of infection, the exposure to which can be largely controlled. Clean cases are those with no apparent source of potential infection. So with an appendectomy, when you take it out, you do have a potential for infection with that because, you know, sometimes, which you guys don't know this yet because we haven't talked about it yet, but with an appendix, sometimes you can get like an area of pus that surrounds the appendix. So that can easily be punctured or whatever, and you can get all of that infection out into the cavity, you know, so that's why it'd be clean contaminated. Okay, it's important for the nurse to assist a post-surgical client to sit up and turn the head to one side when vomiting in order to what?
A.
Yeah. The nurse observes that a post-surgical client has hemorrhaged and is in hypovolemic shock. Which nursing intervention will manage and minimize hemorrhage and shock?
B? I'm not sure about that.
I know that's kind of a weird one too. But yeah, so with this, you definitely wouldn't want to elevate the bed because typically if they have a low blood pressure already, that's not going to make it any better. So typically you would put the head of their bed down with their feet up a little bit and that would help their pressure more. Rubbing their back isn't going to do a darn thing for this. And then encouraging them to breathe deeply. If you're in shock, you're like freaking out usually, and that's not going to help, you know? Okay, which action should a nurse perform to prevent deep vein thrombosis when caring for a post-surgical client?
A.
Yeah, I would say A also. All right.
Okay, which is a classic sign of hypovolemic shock?
B maybe? I'm thinking A or B, but
Think
I
about
don't
this
know.
for a minute. So
hypovolemic.
you're going to have concentrated urine, right? Hypovolemic, you don't have enough volume on board. You don't have enough fluid. So you'd have concentrated urine. Remember we said you'd be breathing fast. So it's not going to be bradypnea. You're going to have a low blood pressure and you're going to be pale, right? Pallor. Okay, the primary objective in the immediate post-op period is what?
Well, using the ABCs, it'd have to be B, right?
Yeah, B.
I would think so. Honestly, all of these things are important, right? But, you know, if you're thinking priority wise, it would be B. Okay. So another thing we'd be doing would be pain on this test. So I'm just going to do a couple pain questions with you as well. Now, when you are reviewing about pain, I wouldn't go too crazy about looking at the pain chapter, but maybe look in your ATI book more so than anything. Chapter 4 in your ATI book is all about pain. Let's see.
So on a side note, does everyone have enough toilet paper?
You're all about the toilet paper, huh, Brandon?
I had a big package delivered to the house, and I feel like I have gold.
That's funny. Can you guys see this still?
Yeah.
Okay, good.
Yeah, I can see it.
Okay, so this is the pain stuff. So when you're looking at the pain stuff, I want you to concentrate on the stuff about opioids for sure, because you're going to need to know like possible complications you could see from opioids. You also need to know the difference between tolerance, dependence, and addiction. And then you also need to know about some of the other things that you can do for pain, you know, as far as non-pharmacological and all of that. Okay, so for this question, when a client who has been taking opioids becomes less sensitive to the drug's analgesic properties, that client is said to have developed what?
A.
Yeah.
Maybe.
Yeah, so here's where it explains everything. So tolerance is when you take something over a period of time and then it was working at first, but now that you've taken it for a long period of time, now it feels like it's not working as good. So maybe before I was taking Percocet 2 every 4 hours, and now I feel like I need 3 every 4 hours, you know, to take care of my pain. So that's tolerance. Prostaglandins are chemical substances with what property? Boy, this is a stupid question. Just give me a guess.
See?
Now, if I can get my computer to cooperate. So they increase the sensitivity of pain receptors. That's not something I would ask you. Which is a true statement regarding placebos?
I would say D, maybe. What?
B.
Huh.
Placebos should never be used to test a client's truthfulness about pain.
Oh, yeah, that's true. I wasn't thinking. Sorry.
Okay, I was going to say. Yeah, so you always take the client's pain for what they say it is, regardless if you believe them or not, you always take it for what they say it is. So if they say they're at a 10, you say, okay, they're at a 10. I need to give them something for pain.
Yeah, that makes sense. I don't know why I said D. I was thinking maybe it's the least invasive, but that shouldn't matter.
Okay. Regarding tolerance and addiction, the nurse understands that. Anyone have a guess?
A.
Okay, good. So although clients may need increasing levels of opioids, they are not addicted. So physical tolerance usually occurs in the absence of addiction. Tolerance to opioids is common. addiction to opioids is rare and should never be the primary concern for a client in pain. Okay, which route of administration of medication is preferred in most acute care situations?
C.
Yeah. The nurse needs to clarify or carefully monitor a client with traumatic injuries. How should the nurse check and document the client's pain?
A.
Yeah. So typically it's common, you know, in the acute care setting to just check pain every time you check their vitals. In which case is it most likely that pain management may not be readily forthcoming to an adult client who is in pain? This is worded kind of funny, but I think it's this one. When the client's expressions of pain are incongruent with the nurse's expectations. Do you guys agree?
I'm not sure because I'm not really getting the question. That, like you said, it's kind of.
It's worded weird. So it's basically saying when you are thinking about managing someone's pain, what's going to be something that it's hard to even explain. So when you're managing someone's pain, what's going to make you think that someone needs pain medicine, basically? So when down here, when it says when the client's expressions of pain are incongruent with the nurse's expectations. So like if they're very stoic, but yet they're telling you they're a 10, then you may not even think that they would be in pain, you know? Usually you expect to see other things that they do to make you think that they're in pain, right?
Oh, yeah, I get it.
Okay, about which issue should the nurse inform clients who use pain medicines on a regular basis?
B, but I'm not sure. I'm between like, I don't know.
I think you're right. Yeah, so the big concern is that if people just take a bunch of over-the-counter stuff for pain all the time, you need to be really telling your physician if you're taking a ton of aspirin or a ton of ibuprofen or whatever, because if you're not following the recommendations about how much you should have per day, that can cause you big problems, like with your liver or your kidneys or something, you know? Okay, which nursing intervention should a nurse perform when caring for a client who is prescribed opiate therapy for pain?
B.
Yeah. Because remember, respiratory depression would be a big concern. Which condition is a heightened response that occurs after exposure to a noxious stimulus? Just give me a guess.
What does noxious mean?
Just a strong smell.
Oh, okay.
Maybe D? I don't know.
Yeah. All right. So again, with this pain stuff, just look at that chapter 4 in your ATI book, and I think it'll probably be good enough. You do have a couple of questions concerning PCA pumps. So if you're not familiar with that, make sure you get familiar with that. But other than that, I think the rest of it should be pretty easy with the pain questions. Okay, so that's all of that stuff. Also, don't forget on this test, we will have a couple of things about IVs on there. So things like, you know how we talked about what's an infiltration, what's phlebitis, what's, you know, some of those different complications that you can have with an IV site. So what's the difference between infiltration and phlebitis?
Phlebitis is when the whole vein is inflamed and you can kind of see the redness traveling up, right?
Yeah, it's like a red streaking along the vein. So you will have pain with that. And, you know, it might be warm to the touch and all of that. So with that, if you do see phlebitis, you would definitely discontinue the IV site, right? What's infiltration mean?
Infiltration, isn't that where the needle or something moves into the tissues, the surrounding area?
Yeah, so if you have an IV site in and you're hooked up to fluids, whenever they give you fluids, now the fluids aren't going to go into your vein anymore. They go in the tissue surrounding it. So if this is happening, what do you see?
Swelling.
Blanching.
Okay.
The area is hard.
Not always, but it can be. What
The pallor.
pallor?
Yeah. The discomfort. Maybe the skin might be.
So
It's supposed to be hot or cool. One of the two. I think
it's cool. It's cool to the touch. And this is right where the IV goes in at. If you feel that site, it's definitely a different temperature compared to the rest of the skin around there. So that's always a red flag. So with infiltration, you always want to think about the swelling, that coolness right at the site, and maybe it might be leaking as well. So like leaking around the site or anything, all of that's infiltration. You don't necessarily have pain associated with that right away. So don't think pain associated with infiltration. That would be more so with phlebitis and some other things. So think just the simple things with infiltration. What's extravasation mean? Do you guys remember that?
I don't remember.
I don't either.
Okay, so extravasation is the same thing as infiltration, but this is the difference. So if I have just plain D5W or normal saline or something simple like that going and my IV infiltrates, I'm fine. I don't have any issues usually. But when I have extravasation going on, this means that I have something more significant that's running through my IV, something like a chemotherapy or maybe a really strong drug like a dobutamine or a dopamine. And when it infiltrates, it causes damage to my tissue. So, you know how we just talked about infiltration, it doesn't really cause damage to your tissue. So after a while, your skin will go back to normal, no problem. But with something like this, when it infiltrates, it actually might cause necrosis or sloughing of your skin, all kinds of craziness. So anytime you would see something like this happening, you always want to call rapid response right away. And they usually will come, and if there's an antidote for whatever this medication is that they got, they will give the antidote, and hopefully it will help so you don't have all of those really bad effects. Make sense?
Yep.
Okay. So those are some of the complications that I would want you to know. And then as far as the hypotonic, hypertonic, isotonic IV fluids, you need to know that. There's going to be a couple questions on those. So I would just review your video that I had posted. I think that kind of sums it up pretty good. And she even has practice questions on her site. You could go to her site and do practice questions on that. Trying to think. I think there might be a couple questions on central lines as well. So with central lines, what would be some ways that we could prevent central line bloodstream infections?
Maybe using like clean or sterile technique.
Well, clean and sterile are two different things. So which
Oh.
one is it?
I would guess sterile technique.
Sterile technique, definitely. Why is it important to use sterile technique with a central line?
Because it goes right to their heart.
Yes, yes. So how often are you supposed to change a central line dressing?
5 to 7 days.
Yeah, usually it's a week. So it's a week, except for if you have like wetness or something already on the dressing, like if it seems soiled or something, then you can change it sooner. Or if it's not occlusive, then you could change it sooner. But generally, we want to keep it still for 7 days without doing that. What are some other things that might help prevent central line bloodstream infections?
Could just flushing the line help?
Yeah, but that's kind of not what I'm looking for.
Proper ways when someone accesses it,
Okay.
make sure you are using, like wiping it off with alcohol or whatever they use.
Yeah, so scrubbing the hub, right?
Yes.
So scrubbing the hub, and we usually do that for a good 15 seconds. And then we let that dry before we give something through there, right? So those would be a couple things. And then also just think about two other things I want you to think about as far as preventing central line bloodstream infections. So we have a specialized team that puts its central lines in. It's not just anyone who can put them in. You have to have special training. So typically at different facilities, they will have a certain team of people who do this, and that's all they do all day, all over the hospital. And when they put these in, it's a totally sterile environment. They like gown, glove, mask, everything. And there's someone in the room that watches them as they do all of that, and they document that they have not broken sterile technique throughout the whole procedure. They don't let anyone come in and out of the room when they're doing this. They drape the patient really good. They clean them with chlorhexidine really well before they put the line in. You know, everything. They just make sure that they really keep sterile technique really well. Another thing to help prevent central line bloodstream infections would be to not keep them in for so long. So every day, you as a nurse need to take it upon yourself to ask the physician if it's needed anymore. So, Dr. So-and-so, do you think that we need this central line anymore? Can we get rid of it today? Because the longer they have it in, the more at risk they are of getting an infection, right? Okay, no one's saying anything, so it makes me wonder if people are still here, if I'm talking to myself. Okay. So those are some of the things I would pay attention to with the IV stuff. Trying to think. Okay, so let's go into the orthopedic stuff. All right, so with orthopedics, remember the first thing we talked about was fractures. What do you remember about fractures?
There's different types.
Okay, do you guys know the difference between the different types?
Talking like green stick, compound, all that stuff.
Yeah.
Yeah, I think I remember.
Okay, so tell me.
Oh, okay. Green stick is where it bends, doesn't quite break.
Okay.
You've got like the compound fracture where it sticks out of the bone.
Out of the skin, you mean?
Yeah, that's what I meant. Sorry.
Yeah, yeah.
I'm trying to think. Oblique, is that the one that twists? No. I don't know. There's one that spiral. I think it's
Spiral.
called a spiral fracture.
Yeah.
There's another one where it's like powdered inside your body, continuated, something like that.
Yeah.
That's all I can remember, I think.
Okay. So you definitely need to know the difference between those because I know there's a specific question on that. Now, when you have someone who has a fracture, you know how we talked about like if you were out in the community and someone had a fracture and you were trying to treat it yourself, the stuff that you would do. So you would be worried that they would have a problem with infection, especially if they had the fracture that sticks out of their skin, right? So what would you do for that?
You elevate the extremity, right?
Yeah, you elevate the extremity, but you're going to want to put a dressing over it, right? Of
Oh, I
some
see.
sort. So you're worried about infection. So you want to make sure you keep that as clean as possible. So hopefully they don't get infected there. All right. So some of the big things to worry about with fractures, again, you want to know those different types. And then you want to know how it's going to get treated. So there's a couple of different ways it can get treated, right? So I'm sure you all know someone who's had a fracture before that's just been like a small, tiny fracture that didn't go all the way through the bone, that maybe they just had to have a cast on, right? So what's important to know about casts?
Don't put anything down it.
Okay. What else?
Make sure it's not too tight.
Okay. So you should always be able to fit like a finger in there, you know, 2 fingers or something down in there. If you don't have that much space, that's a problem.
Did you say something about compartment syndrome with casts?
You could have compartment syndrome with casts, you're right. So what would be some red flags to make you think that maybe they're having that?
Swelling, maybe, or no pedal pulses.
Yes. So the pulseless thing is a really big thing with this. But when someone has a cast on, that's not always real easy to tell, you know, about their pulse. So definitely the swelling, usually they're going to have more pain than they've ever had in their life. So like maybe you give them pain medicine and it's still not taking care of their pain like it normally would. What would be some other things maybe you would worry about?
Skin integrity.
Okay, so skin integrity under the cast, is that what you're talking about?
Or under it and then like where it starts and stops.
Okay,
So-
yeah, because it can rub
Yeah.
the cast. Yeah, you're right. So you would always want to put something right there so it doesn't rub. Other things with casts, you want to be concerned about, like if you were the one assisting with putting the cast on, like if it's a fresh cast and like it drying and that kind of thing. Do you remember reading about all of that and how you're supposed to touch it with certain areas of your hand and not others? And
Supposed to use the palm of your hand.
yeah, because you don't want to have indents in the cast. And then how are you supposed to elevate that?
While it's being put on.
No, I'm not talking about when it's being put on, but after you have a cast on, aren't you supposed to elevate it?
Yes.
Above heart level, and then you're supposed to turn it every 2 hours while it's drying.
There you go. Yeah. All right. So those would be some other things we'd be worried about. And then other than casts, what else can we do to treat a fracture?
Contraction.
Traction. So we need to talk about skin and skeletal traction. What's skin traction?
Skin traction is just literally pulling on the skin with weights.
Okay.
And then skeletal traction is usually for the neck, like the cervical, and they literally put pins like in your neck and they hold it down with weights, I think.
Yeah, it's not just in your neck though. It could be in other places
Okay.
too.
I'm just thinking of the PowerPoint picture.
Yeah,
Sorry.
yeah. But so the skeletal traction is actually where you have pins and things in through your bones, and the weights would hang off of that. So you have stuff that's actually physically in your bone. So yes, we need to know the difference between those. And then what are you worried about when someone has traction? What are some traction principles that you should be aware of?
Not to put the weights on the floor.
Yes, that's a good one. Also, like if someone is in bed and they have a bunch of covers in their bed and they push them all to the end, sometimes the covers will obstruct the traction, you know? So you have to make sure that nothing obstructs those weights, that they stay off the ground like they're supposed to, that you never take the weights off just for pulling someone up or something like that in the bed. Anything else? You just want to make sure that they're in good alignment in the bed, that they're not all crooked, that everything is straight like it should be. Other things to worry about. What would be another thing that we could do for a fracture other than traction or a cast?
You said who would be a good candidate for traction?
No, I said, what would be some other things we could do for a fracture that
Oh,
wasn't a cast or traction?
oh.
Splint?
Did you hear me?
You want to splint it, maybe?
An external fixator.
An external fixator could be one. What I'm looking for you guys to say is surgery. You could do surgery, right? So remember, there is something called an open reduction internal fixation that someone could get. And then there's also that external fixator that you just mentioned. So an open reduction internal fixation is what I had when I had my leg broke. So they went in and my break was so bad that they had to put in a rod and screws to get my bones set back in the right place. And they just have stayed in the rest of my life. So that's that. So external fixator would be, hey, I have soft tissue damage in addition to my fracture. And in order to put everything back in place and to help with some of the soft tissue damage, I'm putting in this external fixator that actually sticks out of my skin. And you would be worried about infection with something like that, right? So with skeletal traction and with external fixators, you're worried about infection because this is going in through their skin, it's invasive, and you could get bacteria and things in there real easily. So we would want to be doing pin care every so often, right? So usually once a shift, they want you to do pin care. And this just involves cleaning around those pin sites. Usually you have like a long Q-tip or something like that that you're going to clean with, and probably chlorhexidine or something along those lines. And then what did we say about tenting of the skin around those pin sites? So you're worried that the skin is going to tent up like this, where like say the pin's right here, you're worried the skin's going to tent up like that instead of being flat. So sometimes you will see people have the gauze wrapped around those pin sites, down towards the bottom to like keep that skin, taut down to the bottom. You're also worried about bleeding when you do this pin care. So you don't want to like really scrub a ton around there. You just want to kind of keep the area clean. And then if you have crusting or whatever, you have to be really careful with cleaning that off so that you don't cause bleeding because it's hard to get it to stop. Okay, what else? So when we are assessing someone who has a fracture, remember our neurovascular assessment. So what are those 6 Ps?
pain, pallor, paresthesia.
Okay.
Yeah, it was pain. I think pulse, paralysis.
Oculodermia.
Yeah. Yeah, you guys got it. So just remember, anytime someone has anything going on, whether it's orthopedic like this, or whether it's vascular, when we talk about vascular surgeries in adult too, you always would want to do these 6 Ps. You're always assessing those things because you want to make sure that they have good blood flow through there. And if they don't, they're not going to get oxygenation to their tissues and they're going to have, problems. Okay, let me think. All right, so a couple of complications that we talked about in relation to orthopedics. We already mentioned compartment syndrome, so that could be something that you see whether they have a cast on or not. So if they have that, you definitely want to address it right away because they could end up losing their limb if you don't. So some of the things that they do for this, if they have a cast on, they would do a bivalve technique to kind of open up a little bit of the cast to give that area a way to be able to expand because of the swelling. And then if they don't have a cast on, they may end up having to do a fasciotomy to like open up that area so it has a way to expand. What do we say a fat embolism was?
Is it a pelvic fracture?
It could be. What
Or
other types of fractures are at risk for that?
the tib? Wait.
Like long bone fractures.
Right.
So like if you fractured your femur or something like that, right?
Yeah.
Okay, what else do you remember about it? What is a fat embolism?
Does it have to do with something with the respiratory distress
Yes.
or?
So when this happens, and it would only happen in those specific types of fractures, a piece of intravascular fat would break off and it would lodge in a blood vessel and cause a blockage of blood flow. So your big things to watch for then would be your petechiae type rash, your respiratory distress, your mental confusion, and then like if you drew their blood, they would actually have fat in their blood. So treatment for this is just supportive. If they really are having a hard time breathing, of course you're going to give them oxygen. If they're still having a hard time, you may end up needing to ventilate them and put them on a ventilator. And they say to give IV fluids and meds to increase the blood volume because this helps remove damaging free fatty acids from the body. So those would be a couple of the things to worry about with fractures. Then we spent some time talking about osteoporosis as well. So what do you know about osteoporosis?
It's a deterioration of the bones.
Okay. Who is more at risk for osteoporosis?
Older folks, because it's usually wear and tear.
No, you're thinking You're thinking of-
Menopausal.
Brandon, you're thinking of arthritis. I'm talking osteoporosis.
Sorry, you're absolutely right.
Menopausal women.
Yes, postmenopausal women. And then is there a certain like type of woman who is more at risk than others?
Petite.
It's usually Go ahead.
Caucasian.
Asian and Asian.
Caucasian and Asian women. Yeah, you're right. Now, men can still get osteoporosis, but women usually will get it more often than men. What other things can make you more at risk for this?
Eating and drinking,
Okay.
having a low BMI,
Okay.
Smoking, drinking, alcohol. Now I remember.
Okay. What about your calcium and vitamin D intake? What would it be like if you were more at risk for osteoporosis?
The intake would be low.
Correct. Yes. Also, sometimes people will have just inherited this, maybe it runs in your family. And then, we already said, about sometimes people will have like an estrogen deficit, and that kind of puts them more at risk for this. All right, what would be some common sites where you would see problems with osteoporosis?
Wrists, hips, and spine.
Yes, definitely. So typically when someone comes in for this, they are like, if you were in the doctor's office and they came in for this would be someone who might just have an unexplained fracture. Like maybe they didn't do hardly anything. They just stepped wrong off of their step when they went outside and they fractured their spine, just from stepping that way. So it's usually something unusual like that. And then other things that you would associate with this would be that Dowager's hump, which is that little hump on their back and between their shoulder blades back here. Other things would be, usually they have lots of chronic back pain, like midline and lower thoracic. And then they could have hip fractures or, a back fracture, associated with this. Now, do you guys remember the thing I said about them losing their height a little bit?
Yeah.
So that would be another thing you would be concerned about. So if you saw that, you'd be like, oh, geez, this person probably has osteoporosis. So what's the test that we would do to tell us that this is what they had?
A bone density.
So it's a bone mineral density test. So you see it called a bunch of different things, but DEXA scan or DXA scan, dual energy X-ray absorptiometry. There's all these different names for it. But basically, this is just looking, it's testing that density of your bones, because the denser your bone is, the stronger it is, right? So this is not like a bone scan. That's a totally different test, and it's not testing for this. This is different. Other things that you could do, you could test their vitamin D intake, like with a vitamin D level, you could do a calcium level, some of those types of things. But when we're talking about prevention of osteoporosis, what would be things that we would focus on, things that we would tell people to do?
Get vitamin D.
Yeah, and how do we do that?
Orally or from the sun.
Okay, and if you tell people to go out in the sun, how long should they be out for?
Is it 30 minutes to an hour or hour to 2 hours?
Yeah, probably 30 minutes to an hour daily, if they could do that. And then you would always tell them about protecting themselves from skin cancer, by doing, putting sunscreen on and whatnot. If you take vitamin D orally, that would be a good thing as well. A lot of people do that. What else could you do?
You do weight-bearing exercises.
Definitely. So with weight-bearing exercises, what would be some examples of that?
Just walking, things that are low impact.
Okay. What else other than just walking?
Resistance stuff.
Yeah,
Water
those are
aerobics.
good. Water aerobics would be another one. So yeah, we could do that. And then if we knew that this person had an issue with like estrogen in their body, they didn't have enough, maybe we would replace that, have them on estrogen replacement therapy. We would also want them to increase stuff in their diet of calcium and vitamin D, right? So what are some things that are high in calcium and vitamin D?
Milk, orange juice, green leaf vegetables,
Okay, definitely. A lot of times you'll see different things out there that are fortified in those as well. Like I know when I buy butter at the store, sometimes the butter is supplemented with vitamin D or something in it. Okay, so definitely when you're looking at osteoporosis, make sure that you know about those things for prevention, because I know there's a few questions on that. And then also who's more at risk. Those are some big things to be concerned about. Do you guys remember, I don't know if I talked about it right here or not. I think I did. Do you remember when I talked about a vertebroplasty and kyphoplasty?
No.
Okay, so we said that surgery is an option here as well. So like if this person did all of these things and they were still having issues, surgery would be an option. So what they would do is, picture this person who has this fracture in their back because of osteoporosis. One of the things they could do is they could go in and inject that area with like a cement of some sort. The cement would set the fracture so it's not going to break, right? And it would strengthen it, and then they wouldn't have that issue anymore. And hopefully they wouldn't have so much pain. So they do this, believe it or not, with a lot of older adults. So when you get this done, when you come back to the floor, you have to be supine and lay flat for a good 2 hours afterwards. So you cannot get up. And the reason for that is because it's cement that they just injected in there. And if you move, it's not going to set in the right place and you won't have a good result. Okay? There is a little bit about that in the ATI book when you're looking at that. So you guys can take a peek at that. All right. And then we did talk a lot about hip fractures and a little bit about knees. What do you remember about hip fractures, you guys?
Caucasian males have the highest death rate.
Okay. If someone falls and fractures their hip, what kinds of things would you see? What would be your signs and symptoms?
One leg is shorter than the other.
Yes. What else?
And I think it's hyperflexed, or what's the word I'm trying to think of? Like it's twisted to the wrong way. It's like outward.
Okay.
Would they have confusion?
They might, but not necessarily. So your big things is, hey, they're going to have a ton of pain there. They aren't going to be able to stand up and put weight on it. The affected leg is shorter than the other leg. And like Brandon said, it's going to be rotated out. So you're going to have an external rotation of it. Let's see. And then a lot of times you'll have like lots of swelling and bruising over that area that was fractured. So those would be your big things you would see. So with hip fractures, people who are more at risk would be people who are older, people who have a history of osteoporosis, and also people who have other chronic conditions. So one of the things that we would make sure that we did for this person, if this person came in and they had a fractured hip, it depends on where the fracture is at, on what exactly they do for surgery. Like sometimes they have to totally do a whole replacement, and sometimes it's just like a pin in there. It just varies on where it was broke at. But basically, if they come in and they can't get surgery right away, you might put them in Buck's traction. And Buck's traction is a type of skin traction. And the reason for this is it helps remove or relieve the spasms that they would have, because they get a lot of spasms in that leg, and that's what's giving them most of the pain. So typically they feel a ton better once you put them in this traction, because they have that pull and the leg is in the right position and it just doesn't hurt as much. Other things, of course, they would take them to surgery eventually, right? And so you would have a dressing on that hip. And of course, you're going to have swelling. Of course, you're going to have the bruising still. But some of the things that you would do post-op, you would be putting ice on that hip, 20 minutes at a time to help with the swelling. Other things that we would do post-op, we would want to get them up pretty quickly after surgery. And physical therapy is going to be working with them to make sure that they can move around using a walker or a cane or whatever, usually a walker. Other things, things that they would be at risk for. So again, here's where our fat embolism syndrome comes into play here. Other things you'd be worried about would be infection of that site, that they just fixed. And then you also are worried that this person's going to dislocate their hip after they just got it fixed. So usually this person's on hip precautions. What are your hip precautions, you guys?
You don't bend a certain amount. I forget, like you don't,
No more than 90 degrees, right?
that's what it was.
So like if you have to bend down to put your socks or shoes on, that's not going to be a good thing, right? What else?
You condition and abduction,
Okay,
and you avoid internal rotation.
definitely. So remember we have that abduction pillow that we use a lot of times after surgery in people in bed. So it's an actual pillow that keeps their legs apart and it keeps them in good alignment so they don't like cross their legs or do anything crazy. Anything else we're forgetting?
If you put them in a chair, make sure it has arms.
Okay. You usually want to build the chair up so it's not so low to the ground for them, right? So your big things with hip precautions, again, I'll just repeat real quick. So if you're turning the patient in bed, you don't want to turn them on that affected side. That's a no-no. You don't want to internally rotate their toes. So no internal rotation, no crossing the legs. Avoid the low chairs. You want to build chairs up. If you do have a low chair, build it up with pillows or blankets so they're not sitting so low. Make sure you have chairs with arms so they can have something to push up and down with to get in and out. Avoid flexion of the hip greater than 90 degrees. Use that abduction pillow when they're in bed. And then like even for when they go to the bathroom and stuff, they may need to have like an elevated toilet seat or something, to help. So those are your big precautions that you would have to be concerned with. All right. So one more thing I just want to talk about a little bit and then we'll get off here because we've been on here for freaking forever now, it seems like. I just want to talk a little bit about the different types of arthritis and gout, because that would be another thing that's on this test. So we talked about osteoarthritis and rheumatoid arthritis. So can anyone tell me the difference between the two?
Yeah, this is what I had confused. Rheumatoid is the one that's like infection and it's usually bilateral. And then osteoarthritis is the one that's wear and tear and things like that.
Okay, anyone else have anything to say? Okay, so with osteo, let's talk about that first. So osteo is wear and tear of your joints. Usually this person will have certain things that may clue you into that they have this. Like they're gonna have stiffness in the morning, and usually when they get up, if they start moving around, the stiffness goes away and then they start to loosen up and they feel better. And that doesn't last for like a super long period of time. It's usually just for a little bit when they get up, and then as they get moving, they feel better. Other things, sometimes people will have osteoarthritis so bad, like say they have it in their knee. Sometimes you will actually hear crepitus because you'll have that bone rubbing against bone as they're moving their knee. And so you'll hear that cracking sound. A lot of times they'll have lots of swelling and pain in their joints. Other things that we want to know about osteo. So usually you have those Herbidens and Bouchard's nodes. Do you guys remember looking at that? So Herbidens nodes are the ones that are distal, I believe. And the Bouchards are the ones that are proximal. So these are those like bony prominences around their finger joints. So like if you were looking at these, if you were pushing on them, they would feel bony and hard. And a lot of times when people have osteoarthritis, if they're overweight and they can lose weight, that might help some of their symptoms. That would be better for them. So things that we would do for osteoarthritis. Now, you would treat their symptoms. So of course you could give them NSAIDs. NSAIDs would help with the swelling and it would help with their pain a little bit. A lot of times people will take that glucosamine chondroitin over the counter, and that kind of helps with some of their symptoms. There's a lot of like creams and lotions and different things that you could do for some of the symptoms as well. And then for osteoarthritis, you could actually do, the joint replacements, and that would actually fix the problem. That would be the only thing that would really fix this is if you replace the whole joint. So that could be something. And then they also could do, physical therapy and stuff like that to help with some of their symptoms. So that's osteo. And then rheumatoid is something that is autoimmune. So you have exacerbations and remissions with rheumatoid. So this means that you will have rheumatoid the rest of your life. You cannot get rid of it. And there'll be days where you feel fine, and there'll be other days where you feel really bad. So the times where you have exacerbations, these are times where you should be splinting your joint and you should not be moving it. Usually, with osteo, they want you to keep using your joints because if you don't, they say if you don't use it, you lose it. So with rheumatoid though, when you have an exacerbation, you want to splint that joint and keep it still and like treat your pain until you get through that exacerbation. And then once you're feeling better, then you can start doing your exercises and moving around more. The other thing with rheumatoid, with symptoms. So with symptoms, they're going to be similar, but a little bit different. So with your symptoms, you're going to have the stiffness in the morning, but usually it'll stick with you longer than the person with osteo. The other things with this, you'll still have those Herbidens and Bouchard's nodes, like on your fingers, if you were looking at the fingers. However, when you feel them, they're going to feel different. So like if I was feeling this one, it might feel soft and boggy. And it actually may feel warm to the touch, like inflamed like. The other thing, symmetrical, you have symmetrical effectiveness, I guess, on both sides with rheumatoid, whereas with osteo, it's just on the one side usually. Trying to think what else. Other things, so with treatment then with rheumatoid, You actually have what am I trying to say? The DMARD drugs, that you could take. So the DMARDs, there's a couple of different kinds, and I don't know if you remember the PowerPoint, but like the last one that I talk about, those biologic immunomodulator ones. So those actually will cause your immune system to be decreased. So you're going to be more at risk for infection while you're taking these drugs. So they do help quite a bit with symptoms of rheumatoid, but just be aware that that's a huge side effect of those drugs, that your immune system is down and you could get sick really easily with other things during that. Trying to think. Do you guys, am I missing anything with those?
I just have a question. For
Yeah.
rheumatoid, that one, the joints can like fuse together. Can that happen with osteo?
No, your joints will not fuse together with osteo. It's only with rheumatoid.
Okay, thank you.
So that's kind of the gist with those. And then we did talk about gout a little bit. So what is gout? Do you guys remember?
Build up
Uric
of
acid.
uric acid.
Yeah, so you have a buildup of uric acid in your system, and it actually will go to your joints. So it's kind of like an arthritis. It's a type of arthritis. So with this buildup of uric acid, if you can just think of it like these little crystals that kind of form together, and they can make a big, like pointy thing that can be very painful in your joint. So typically when someone has gout, it's going to come up, like the acute form of gout will come up out of nowhere. So you'll feel fine one day, and then another day you may get up and totally have problems with gout. So when I was talking to you guys about this in class, I said the big toe is usually the big place where people feel it the most. And so your toe would be like super red, swollen, and you can't stand anything touching it. It feels that bad. So like even a sheet barely touching it bothers you. Other symptoms that you could have, sometimes you have flu-like symptoms associated with this. Typically though, it's mainly the stuff with your joint. Like you have all this pain, you have the swelling, you have the redness, and then maybe just like you feel achy and flu-like. So what they would do for this, they try to keep that joint still for a couple of days until they can get the swelling down. So once you get the swelling down, usually that feels a little bit better. So maybe they might give you a corticosteroid for a short period of time to get the swelling to get better. And then there's some medications that they give to help with these episodes. So we talked about colchicine and allopurinol. So allopurinol is the one that you'll probably see more often than the colchicine, but typically that will help. Then the other things we said with gout is that, you want to increase your fluid intake. So if this person has lots of fluids that they take in, like 2,000, 3,000 cc's a day, that may be beneficial to help get some of this uric acid out of their system. Other things we said, you want to stay away from purine-rich foods. So remember we said, like I think we said any kind of alcohol, organ meats, anything like that would be an issue for this person because it's going to cause the buildup of uric acid. What else? Those are probably the big things. And then we did say that there is a chronic form of gout that you could get. And this person would typically be the person who has chronic kidney disease. And because they have chronic kidney disease, they're not able to excrete everything that they normally would. And so that's why they're more at risk for this. So this person will constantly have high uric acid levels. And as a result of this, they get these formations of things called tophi. And tophi can be in different places on the body, but it's just a formation of uric acid. Like the one in my one PowerPoint, it had a picture of one on someone's ear. So it's not necessarily just there that you would see those. You would see them in other places too. So again, this person would be someone where you would just have to teach them some lifestyle changes to kind of make things a little bit better. And then they would constantly be on medication for this. Questions about any of that?
Do the medications stop or just help to prevent?
So they typically help to prevent another episode. Like if you're on it daily, then you're not going to have an episode. But yeah, so it's really more of a thing that the patient has to do some lifestyle changes to really help so they don't keep having this happen. Trying to think if there's anything else I'm forgetting to talk about. We did talk a little bit about amputations, and there's not that much to know about those. You guys can review your PowerPoint on that. Trying to think. I can't think of anything else. Do you guys think of anything that I'm forgetting?
I can't think of anything.
Okay, so when you see your test on Thursday, the first probably 25 questions would be stuff about intra-op, pre-op, post-op, and pain. And then the last part of the test is going to be on your orthopedic, everything that we talked about, and minus 2 questions, which would be your math. Okay. So
Is the test, oh, I'm sorry, question. Is the test going to be started at 9 a.m.?
So I will probably have everyone come in a little bit early because it's our first time doing it. And we want to make sure everyone gets on okay and we're not having issues. So are you guys okay if we start at 8:30? It doesn't mean we'll start the test right at 8:30, but if everyone tries to get on and we get everything hooked up like we need to, then we can get started.
So we're going to have 2 programs running, right? We're going to have Zoom so you can watch us. And then there's going to be that vSim where they can not vSim, the other program where they can watch our screens.
Yeah, so we will hook up to Zoom, and then I think what's going to happen is we're going to have a code that I have to have you put in to get to your test. So you will have to be logged into Canvas because your test is on Canvas, and then we'll be in on Zoom so we can talk to each other, and then you'll all hook up to that Land School Air, and that Land School Air is the one that I can look at your screen and make sure you're doing what you're supposed to be doing. So it's like multiple things we're doing all at one time, basically.
Okay, so we're just getting on Zoom at 8:30, and then you'll give us instructions from there, basically.
Yes. Which I hate getting on here at 8:30, but whatever, we'll deal with it.
Well, just go easy on us. It's our first online exam.
Yeah, do you guys feel better after we just talked about all that or not?
Yes, this is helpful.
Yeah, I feel a lot better too. I've been nervous.
Yeah.
Yeah, okay. It's really, this test isn't that bad, I don't think. Okay, I guess I'll get off here. I don't know if you guys realized, but they changed our Zoom thing. So before I was always cut off after 40 minutes. So they got us the Zoom Pro now. So now we don't get cut off anymore. We can talk as long as we want.
Oh.
So we'll have to thank Dean Newman for that one.
I had a question about the vSim. When I had looked on Canvas, are we to do those worksheets or just do the assignments on DocuCare?
The worksheets are just for your benefit. If you want to do it that way, you can.
Oh, okay.
They just have all of these different options for you to do. You know, it's up to you.
Okay. And then also, did you receive my email? Because I had to send it through my personal email for the case studies. It wouldn't send through my school email for some reason to you.
Okay, I'll double check when I get off here to see, and
Okay.
I'll let you know.
All right.
Okay, so one last thing. So we're logging on Zoom, and then you're gonna tell us how to get into the Lands Air, and then we need to go to the Canvas after we get to Zoom first.
Yes.
Okay.
Yeah, I think it'll be fine, you guys, and hopefully at least we'll finally get some of this out of the way, and so hopefully we can get moving on with the rest of our stuff.
I'm
All
just
right.
glad we're pushing forward and we're not being delayed graduation, you know?
I know, this has been crazy. Okay, so I apologize that things have been so weird, you know, and I hate that I have to constantly put 3 million announcements on your board about stuff. It's like no good way to communicate with everyone. So just keep looking at your announcements. I will put something on there today that talks about the dates that we talked about for our tests. So you have that. And I'll also reiterate when things are due on that same piece of paper. So I'll make it as an attachment, and then you could just print it out so you have it and you know when everything is happening.
Oh, Miss Silk, are you able to still share this video so we can use it to study as well?
I think so, yes. Now,
Okay.
sometimes when I don't post, it's because I've lost it somewhere and I can't find it. So I'm pretty sure I know where it's at now. So I think I should be good. All right. Everyone good? Can I get off of here?
You're ready to go.
Well, it's been a long time. Cripe.
All right, Miss Silk, thank you so much for today.
All right. Thanks, you guys. If you have any questions, you can get a hold of me. You can always call me too. All right. Have a
Thank you.
good afternoon.
Thanks, you too.